Dr. Neena from the Giridhar Eye Institute. Neena was our faculty in Shankaretralaya, Kolkata as well. And we're very proud of all she has been doing. Over to you, Dr. Neena.
Thank you, ma'am. I hope you can see my screen.
Yes, we can.
Yes. So from atom to lamp, what we know about low-dose atropine, that's my talk. Let me thank AIOC2021 and Dr. Meenakshi for this opportunity. So ever since myopia has become a booming epidemic, a lot of novel treatment modalities have come to control the progression of myopia in childhood. Low-dose atropine is an emerging treatment modality which has caught the fancy of many, and we'll see why and how. Why do we like atropine so much? First of all, it has been around in ophthalmology for a very long time and has been shown to be consistently effective in slowing myopia progression with a good safety profile. So there have been a multitude of studies, in this regard, but it was a landmark study called the Atropine for the Treatment of Childhood Myopia by Chua et al., which was published in September 2006, which validated the efficacy and safety of topical atropine in slowing the progression of myopia in Asian children. So this was a randomized, double-masked, parallel group, placebo-controlled study in about 400 children aged 6 to 12 years with a spherical equivalent of -1 to -6 diopters. So they looked at the effect of 1% atropine drops or placebo eye drops once at bedtime for 2 years. And they looked at the change in spherical equivalent and axial length over 2 years. About 86.5% children completed the study, and they found that in the atropine-treated eyes, myopia progression was less. Axial length remained unchanged, and the differences in myopia progression and axial elongation between the two groups were statistically significant. So they concluded that over 2 years, atropine 1% eye drops slowed myopia progression by 77% with no axial elongation. It was well tolerated and effective in slowing progression of low to moderate myopia and axial length in Asian children. However, the undesirable side effects of 1% atropine, like blurry near vision, photophobia, and the risk of increased UV exposure and the need to wear photogray glasses and progressive lenses deterred its widespread usage. So researchers have been looking at lower concentrations, and in 2016, Adrichia et al. Published their 5-year clinical trial on atropine for the treatment of myopia, which is popularly called the ATOM-2 study. So this compared the safety and efficacy of lower concentrations of atropine, 0.5, 0.1, and 0.01% in myopia control. Again, it was a randomized double-masked clinical trial, and they had 3 phases in this. Phase 1 was a treatment phase in which each eye received atropine for about 2 years. Phase 2 was a washout phase in which all medications were stopped for about 1 year. And phase 3 was they looked at the rebound myopia progression on stopping the drops. And if anybody had progressed beyond or equal to more than 0.5 diopter, they were restarted on 0.01% atropine eye drops for another 2 years. So the parameters assessed in each visit would be cycloplegic refraction, axial length, pupil size, accommodation, and visual acuity. And they looked at the change in spherical equivalent, which was analyzed as a primary outcome, and the change in axial length was calculated as a secondary outcome. Again, about 86% children continued to the phase 3. Surprisingly, about 56% of the children had to be restarted on atropine 0.01% at the end of phase 2. That means there was about 56% children had rebound, but this was least in the 0.01% group. So that was the most interesting observation in the ATOM-2 as compared to the 0.1 and 0.5% groups. So they concluded that myopia progression over the entire 5 years was less in the 0.01% group, and the rate of myopic progression in children who were restarted on atropine 0.01% slowed in phase 3, and they postulated that retreatment with atropine 0.01% was as effective as primary treatment with atropine 0.01% itself. So the key points we understood from ATOM-2 was that definitely there was a dose-related response to atropine in phase 1 with greater effect in higher doses. However, on stopping the drug in phase 2, there was a rebound, inverse dose-related increase in myopia with greater increase in greater concentrations. Younger children, those with greater myopic progression in year 1, were more likely to require retreatment. Overall 5-year progression of myopia was less in the 0.01% group. All concentrations were well tolerated with very less side effects. but it was least with the 0.01% group. So they also classified the patients based on the response. A good responder was one who had less than 0.25 diopter per year of progression. And if the child was older than 13 years, they recommended that atropine 0.01% could be stopped. Moderate response, if the progression was between 0.25 to 0.75 diopter per year, then you have to continue the atropine 0.01% till it reduces to 0.25 diopter per year progression or the child reached mid to late teens. If there was a poor response, that means myopia was progressing beyond 0.75 diopter, then atropine had to be stopped and they did not recommend any further treatment. Now, the strength of the study was obviously its large population with a long follow-up and randomized double-blinded design, but the concern was an absence of a placebo control group with which you could compare the data with. And the fact that despite 0.01% being the best concentration, there was a significant axial length elongation in that group of about 0.4 millimeters at the end of 2 years. So if you compare the ATOM1 and ATOM2, you can see that ATOM2 had slightly older age group, slightly higher levels of baseline myopia. In comparison to the ATOM1, in which there was a hyperopic shift in the initial 8 months, continued myopic progression was noted in all the groups in ATOM2 till it started to stabilize by 8 to 24 months, and there was a plateauing with maximal effective myopia control in the second year. Now, a lot of unanswered questions were still there, and which is the best concentration people wanted to know. So Jason Yam et al. From Hong Kong University is currently doing this quadriphasic study called LAMP, low dose atropine for myopia progression. This is a quadriphasic study, phase 1, phase 2, phase 3, and phase 4. Phase 1 and 2 results are out. 1 would be treatment phase, 2 is continuation, 3 is washout, and 4th is the extension phase. So phase 1 results were published in 2019. They looked at the efficacy of 0.05, 0.025, and 0.01 compared with placebo over 1 year. And the profile of children was similar to ATOM2, and they found that there was a concentration-dependent response to the 0.05, 0.025, and 0.01% atropine in myopia control. And they found that 0.05% atropine was the most effective in controlling progression and axial length elongation over a period of 1 year. They continued the study to the second year, and these results were again published as LAMP2 in 2020. And here, the group of concentrations of atropine, the various groups of concentrations of atropine were continued to the second year, and the placebo group was crossed over to the best group at the end of first year, which was 0.05%. And again, they found that the mean spherical equivalent progression and axial length change was lowest for the 0.05% atropine group. So they concluded that 0.05% remained this optimal concentration among the studied groups in slowing myopia progression. So to summarize, the evidence for atropine would be ATOM1 showed that atropine 1% slowed myopia progression significantly by 77% over 2 years with no axial length increase. ATOM2 showed that 0.01% retarded myopia progression close to 50% with least side effects and rebound, but axial length increase was a concern. LAMP showed that lower concentrations were equally good, but 0.05% was the most effective. LAMP2 confirmed the findings that 0.05% was the best concentration at the end of 2 years with an efficacy of 64.5% with an effect double that of 0.01%. So what is this anti-myopia effect of atropine? Does it work on accommodation or does it have other effects? We know it works on the muscarinic receptors by blocking it. It inhibits the glycosaminoglycan synthesis in the scleral fibroblasts and prevents the eye growth. The increased pupillary dilatation allows entry of UV light and kind of down-regulates the axial length increase and the chronic inflammatory state of myopia. So these are some postulates, but the exact effect is still to be deciphered. So take-home pearls would be that there is definitely a concentration-dependent response to atropine on myopia control, and myopia is slowed maximum with atropine 1%, but definitely it has unpleasant side effects. Lower concentrations like 0.01 and 0.05% might have a greater effective stop signal for myopia progression in the long run with the least side effects. So you can start with the lowest available concentration, 0.01% at bedtime in moderate to slow progressive myopia. Monitor the treatment with cyclorefraction and axial length. Progression can happen on stopping atropine abruptly, so you may need to taper the frequency or switch over to higher doses. Age-dependent effect is noted, and younger children with early onset of myopia, rapid progression, or parental high myopia may need to be initiated on higher doses. Thank you.